Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Nidhee Sachdev.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Hi everyone, welcome to another episode of the Egg Whisperer Show. I'm so excited to have Dr. Nidhee Sachdev here all the way from Orange County on with us today. Hi Nidhee.
Hey Dr. Amy, how's it going? Thanks for having me on.
Of course, thank you so much for being on today. And one of the topics that I get so many questions about is exactly what you're going to talk about today. We're going to talk about genetics and are patients really doing enough genetic screening? And you have a lot of background in this, so why don't you tell our audience members where they can find you, where you practice medicine, and a little bit more about yourself.
Yeah, great. So my name is Dr. Nidhee Sachdev. My patients call me Dr. S. So I work here in Orange County. I work at a practice called OC Fertility. We're part of the CCRM Orange County network, and here in Newport Beach. I'm a California native. I grew up in the Bay Area, not far from where you are, Dr. Amy. And then through school, I came to Southern California, went to the Midwest at the University of Chicago for residency, went to New York at NYU to do fellowship, and then made our way back here to sunny Southern California.
So we kind of did a lot of traveling, both of us. I went to UCLA, then went to Michigan, Boston, and then back here. So it's a really fun thing to do because we get to kind of learn how people practice medicine in different parts of the country and then take what we like and then apply it to our practice.
Totally,
so that's pretty
yeah.
Cool.
And having that network is super helpful because when patients have questions and you can kind of cast your net and ask and relate to different specialties all across the country. So it's awesome.
It is really awesome. So tell us a little bit about why you went into medicine and then more specifically fertility medicine.
Yeah. So when I was younger, I honestly didn't know exactly what I wanted to do other than I realized I liked science. Having only one family member who was in medicine was an older cousin of mine who was a GYN oncologist. It's a female cancer doctor. He suggested I get a job at a hospital, and I actually got a job at the hospital he worked in as a clerk. While I was there, I got to tag along with him and see him interact with his patients, and I realized that I really liked the relationship he had with his patients, and I liked the science and what he did. So I decided that I was going to buck up, try hard in school, and try to get into med school. So I did, and when I got to med school, I kind of had already an interest in women's health just through my exposure to him. And so I decided to go into OBGYN. And then once I got to residency, I realized that it wasn't really just the idea of taking care of pregnant women that I was interested in. It was really the relationship I developed with them. And hearing and meeting women really in labor and delivery when they had kind of been on the other side of fertility, but just talking to them and hearing about their journey. And, you know, for some it was really difficult, for some it was somewhat difficult, but I realized that was the patient population that I was drawn towards, because part of being a doctor is I like the idea of feeling that I'm making a difference. And I realized that for some people, you can have the ability to make what I felt like was a bigger difference in others. And that's what led me to it. And then I did a little bit of research into it. I got to spend more time with different fertility clinics. And I realized it was just, the more I learned about it, the more awesome it was. And the science was awesome and things were changing. And it was what I was meant to do.
Awesome. Well, your patients are clearly very lucky to have you helping them. Okay, so let's get into our show topic. So you guys all know what the Tushy method is: T for tubes, U for uterus, S for sperm, H for hormones, Y for your genetics. So the first question I have for you: do genetics play a role in infertility?
Yeah, I would totally say they do. For that reason, the most important part of my new patient consultation in the history is their family history. I think it's important to understand, are there any prior known developmental or genetic issues? Were there any issues of fertility amongst their family? How old was their mom when their mom had them? And if they do know what age their mom went through menopause, that's also important information.
Yeah. And what are some genetic causes of infertility in both men and women?
So there are quite a few. I mean, a really important one is anything dealing with chromosomes, right? So one, age can be related to a genetic issue. As we get older, we have a harder time as women having eggs that have the right number of chromosomes. Okay, so that is a big genetic issue when talking about fertility, because as we get older, we're less likely to make chromosomally normal embryos. Other factors are endometriosis. So endometriosis has some familial causes. It's not a directly linear relationship, but having a sibling or a mother who has endometriosis does put patients at a slightly higher risk of having endometriosis themselves. There are other factors, such as inheritable diseases that we can pass on to our kids. And specifically one called Fragile X is one that we can carry that can, one, be associated with having a lower amount of eggs, a lower ovarian reserve, and passing on to our kids to have, again, infertility issues and possibly having kids born with developmental delays.
And what kind of tests do you offer your patients routinely, whether they're trying to get pregnant naturally with IUI, with IVF? What is your go-to set of genetic tests that make you feel like you're doing a very complete job for your patients?
So for all patients, after the history, we talk about genetic carrier screening. So genetic carrier screening is a blood test in which we're able to screen a patient's blood for different inheritable diseases. And there's lots of different ways that we can inherit diseases and we can pass them on to our kids. Some diseases are passed on only through the X chromosomes. And so as women, since we have two X chromosomes, those are ones that we can then pass on to our kids. But boys or men having only one X chromosome, if they do inherit a disease from our X chromosome, are more likely to manifest those diseases. So as part of that, a genetic carrier screen is something that I offer all of my patients, regardless of how they're trying to conceive, so that they have the ability to screen themselves and their partners for these inheritable diseases. Patients will often say, well, does my partner have to have it done as well? So I typically say, one, we can start off with you, right? Because the part of the male that if you test just the male and not the female, you're not going to have that ability to determine if the patient herself, if the female patient has any diseases that she can pass on via the X chromosome. So I recommend that my patients have it done, and that we can determine if they are predisposed risk for any sort of diseases that can pass on through that. That's where I usually start. There are other tests that we can do, chromosomal tests, where we can look at a patient's karyotype to see if, as a woman, if we are 46XX and a male is 46XY. I don't always right off the bat start off with that. It kind of depends what treatment course we're doing and their history.
Yeah, I mean, that makes perfect sense. I just do both at the same time, both the chromosomes and the carrier screen. The genetic carrier screening company that I work with has just popped in 2 green tops for me. I mean, in the old days, doing a chromosome analysis was like thousands of dollars, and now it's just hundreds, just like the carrier screen.
Totally.
So sometimes I do it from the beginning, and sometimes I don't.
We do it for all of our IVF patients.
Yeah.
If someone's going to undergo IVF, we want to know, is there like something abnormal in the chromosomes, like a translocation or reciprocal rearrangement? Because if you're going to go through that and have a much higher risk of having abnormal embryos, sometimes patients will determine, okay, we can't do anything to change our own chromosomes, right? And so some patients will say, okay, if I have a higher risk of having all of my embryos being abnormal, let me try it and see what happens. Or they'll say, well, instead of going down that route, maybe I'll use a donor, whether it's a donor egg or donor sperm. And I've had patients make that decision.
Right. What about for women who are freezing their eggs? Do you think that they should do carrier screening up front first? So
I recommend it to all of my patients. I say, especially if we're concerned that there might be something that they can pass on to their male offsprings, the X. What I do tell them though is that I think it's important that they have it done, but by the time they come back to use their eggs, the carrier screens might be more expanded. So there might be more diseases that they can test for, and their partner, when they then get tested or whatever, whether they use donor sperm or what, might have an expanded carrier screening panel. So there might be diseases they were tested for that you weren't. But yeah, I do recommend that they get it. And some will say, I'll wait until I want to use my eggs, and some just do it after that.
What if someone says to you, Dr. S, I understand you want me to do this test, but I'm not really going to do anything with the results, even if me and my partner are both carriers for the same disease. How do you answer? What's your answer to that?
That's a fair question. And I would say that's totally fine. I said, you can look at information in 2 ways. You can look at it as information for which you don't necessarily have to act on, but it's information for which you can be more prepared in the future. Or some people view information as anxiety provoking, right? Because if it's a recessive disease, which are the most common ones, if you and your partner are both carriers for it, there's still a 25% chance that you could have a baby affected by that. And now you can look at that as saying, wow, there's a 1 in 4 chance. Or you can look at it as saying, hey, there's a 3 in 4 chance that I'm going to be fine. So it totally depends. And I respect everyone's decision. So I just kind of educate them that if they do test, then they can just be prepared, and they can just maybe identify and tell their doctors that they can diagnose their baby sooner. or later. But if they don't want to do anything, that's totally okay.
Right. So it's not required, but certainly I think when we talk to patients, just like you're counseling them in that exact same way, I think they sometimes see it as a different thing. You know, they don't see it as like, oh, if I do it, it means that I'm going to have to potentially end a pregnancy that has a disease or something like that.
Totally. Yeah.
Yeah. So you are very well published in this field, and you know, and so that's why I wanted you for this show topic. And one particular question that I want you to answer for our audience is, how are genetics important when choosing a donor egg and or donor sperm?
So that's a good question. So patients ask me that and they say, well, what should I be looking for? And truthfully, you know, you kind of have to determine, either you or you and your partner, what's important to you, right? Is it, because when looking at a donor, especially for a donor egg, the criteria for a donor is, one, to be of a certain age, right? To be typically in their 20s, so that they have a high reproductive potential. Okay. When looking at a donor, helpful information is to say, have they donated before? How many eggs have they gotten? And what was the outcome of that? Because truthfully, that's the best marker of their fertility. And that's the best marker of their genetic potential, right? Other aspects are, you know, what's important to that person. Is eye color, is hair color important, is ethnicity important? And those are genetic aspects that are important and that oftentimes will manifest, but everybody is different. So when it comes to the genetics, I think the key from the prognosis standpoint, the key is age.
Yeah.
And their ovarian reserve markers, which, you know, will be done by all agencies and clinics prior to them cycling.
Right. And what about paternal age? How does paternal age play a role in genetics?
So that's a good question. I mean, the blame has kind of always been given to the egg, truthfully. And I did a study looking at paternal age to see if there was any association between paternal age and miscarriages. The study I did was specifically looking at euploid or chromosomally normal embryos to say, well, you know, if a 25-year-old has a normal embryo, but her partner is 50 versus a 25-year-old with a 26-year-old partner, does the one with a 50-year-old partner have a greater chance of having a miscarriage? And that study showed that there really was no association between paternal age and chromosomally normal embryos. That being said, you know, that study was done after the embryos have already gone through the selection process. We've selected them to be normal. It didn't take into consideration that maybe that couple who had a higher paternal age had a higher percentage of abnormal embryos, or that the mechanism involved in creating the embryo was already selected. So I definitely think that there is a possibility. And now, you know, we have the ability to do parental origin of aneuploidy, in which we can determine, well, if somebody has a higher percentage of aneuploid embryos, is that really just because of the egg, or could it be the sperm as well? And we've seen, surprisingly, that sometimes there's a greater percentage due to the sperm rather than just the egg. So whereas traditionally I would say 90% of the time the error was due to the egg, I would say now, you know, instead of 10%, I would see sometimes 15 to 20% the error can be due to the sperm.
Right. And when you just brought up something really important, I think, for people to hear. When you say embryos are genetically tested, what exactly does that mean? I mean, can you test embryos for autism, hair color, height? So what does genetically tested embryo mean?
Good question. So when talking about a genetically tested embryo, I'm talking about the process of preimplantation genetic testing, or PGT. And the way that works is that we take some cells out of the part of the embryo which goes on to be the placenta, to determine the chromosomal makeup of those cells, to say that that should be an accurate representation of the remainder of the embryo. And most commonly, when we do PGT-A, A for aneuploidy, we're looking to see, does that embryo have the appropriate number of chromosomes? Does it have 46, like me and you? 23 from the sperm, 23 from the egg. As women, we have two X's, 46XY, and men have 46XX, and men have 46XY. So the point of that test is to say, hey, do these embryos have the appropriate number of chromosomes? In the event that the carrier screening has shown that both the patient and their partner are carriers for the same disease, then we're able to perform PGT-D for diagnosis, or M for medical genetics. In that case, prior to doing IVF, a specific probe needs to be made using the patient and their partner's DNA to identify that specific mutation for that gene. So imagine it like you have Velcro, right? You got the sticky part and you got the fuzzy part. So the probe is like the fuzzy part that finds a specific sequence of that gene to identify it, okay? And so if that is the case, then you're able to look for, one, the chromosomes. If you have 5 embryos, let's say 3 are chromosomally normal, Then you take those normal ones and say, well, how many of these are actually affected with the disease, or how many are carriers? To answer your question, autism, typically no, unless there has been a specific gene abnormality associated with that specific form of autism. We're not able to screen the embryos for that, and we're not able to screen for aesthetics like eye color or hair color and things. And, you know, from my understanding, that's not going to be something that's done in the near future, but, you know, things change, so we'll see.
I hope you're right that we don't do that. What about mosaicism? And again, you've published on that too. Can you tell us, what is a mosaic embryo? What should a fertility patient know about it?
Mosaicism is a really interesting topic that I've spent a lot of time researching about. So mosaicism is when not all of the cells within the embryo have the exact genetic makeup. So if you have 100 cells, maybe 5 of those cells will have chromosomal abnormalities, maybe an extra chromosome 47, and the remainder 95 will have the appropriate 46. Now, what to do with that information is kind of confusing, right? So when we biopsy the embryos, we're taking 5 to 8 cells. And when we go and we get those results, sometimes it'll be clear there's 46 chromosomes. But sometimes the results won't be exactly clear that it's got an extra copy, it's missing a copy, or it's got exactly 2 copies of each. Sometimes the results will kind of look like it's in between. And that's what we diagnose as mosaicism, saying that it doesn't appear that all of the cells in those samples have the same number of chromosomes. Some might have an extra, some might have few little. And so that has really been of a greater diagnosis since we switched the platform to next generation sequencing, NGS, which happened around like 2015. We started to see a higher degree of mosaicism. So when that happened, we had these embryos that before it used to be black and white. Normal, abnormal, right? Normal, yay, you put it in. Abnormal, don't put it in. Then we had this gray. And we're like, well, what do we do with it? And for a long time, we kind of just held them, kind of too scared to put them in. Now we're slowly learning a little bit more about it, and we're slowly, thoughtfully putting them back in. And we're learning about these mosaic embryos that, one, it depends on does it have extra copies? Does it have missing copies? Does it have extra copies of something that's associated with the known abnormality, right? Like something that's mosaic for Down syndrome is a chromosome abnormality, mosaic embryo we're less likely to put in than something that has a mosaic for something not associated with the disease. But we're learning that when we put in these embryos, they are less likely to implant and have a higher rate of miscarriage. But the few studies that have shown that we put them in, they've actually had live births, and many of them have been healthy. I think the key is talking to your doctor and genetic counselor about which mosaic embryos you have and trying to assess, well, what percent of mosaic is it? Meaning that, did it seem like 30% of the sample had an extra copy, or did it seem like 70% had an extra copy? Because that is an important difference. I did a study in fellowship that was recently published where I rebiopsied the embryos myself. And I rebiopsied embryos that were normal, I rebiopsied embryos that were abnormal, and I rebiopsied embryos that were mosaic. And we found the normal embryos were normal. The abnormal embryos were abnormal. The mosaic embryos, sometimes they were mosaic, sometimes they were abnormal. But the key is that if it was mosaic and associated with an abnormal embryo, the abnormal chromosome, it was definitely abnormal. And so it gave us some reassurance that was like, normal is normal, abnormal is abnormal, mosaic has potential. And I think that's important because some people are in a position where they only have a mosaic embryo and they're kind of scared as to what to do.
Wow. Well, I hope that everyone who goes through IVF listens to this show, because I think it's really important for you to know what questions to ask your doctor, because not all clinics will talk to their patients about mosaic embryos. They don't have that setting turned on, for example, on the report for them to even get that data. And so people don't know that that data is available to them. So if you think that all your embryos are abnormal, it's possible that maybe one is mosaic. And I've actually seen it the other way around, where a patient has had a report where all the embryos were normal. And then when she asked for the mosaic report, a couple of them actually came back mosaic.
So it's interesting because I did a study comparing mosaic rates based on the IVF labs. It was all done by the same genetics lab. So all the results, these different labs sent their biopsies to one location. They did the results, and we found that the mosaic rates do vary by the lab a little bit. And to that degree, it probably varies a little bit by the lab doing the genetic testing.
Yeah.
And so I think that's an important concept to talk to our patients about, because you're right about the settings. And so how does each clinic, how does each lab determine what's normal, what's not? And I think for some, they're more inclined to call ones abnormal than normal. And some are more inclined to say, hey, we don't know, no results, right? And that's how our lab is. You know, we are more inclined to say, if we can't tell, we call it a no results, and then we'll rebiopsy those.
Right. And knowing the example that I just gave you was not my patient, because obviously I had that setting turned on and I talked to my patients about it. So I just want everyone to know that. Okay. So for patients out there, and I'm talking more specifically about women, is there a list of things that they should talk to their moms about? If that's possible, as far as like things that run in the family? Do you have like a go-to list, like, hey mom, like for women who are 20, and I'll give you a scenario. Like I had a patient who came to see me, she was like 33, and she was so upset that her mom had never told her that she had gone into menopause at age 35. And if her mom had told her that, perhaps she would have had an opportunity to secure options for herself that she unfortunately didn't have by the time she saw me. So like, is there a list? Like, what are your golden rules as far as genetic diseases that you think every woman should know that about, if they run in their family or not?
Yeah, totally. So yeah, that's a great one. One, mom, have you gone through menopause? When did you go through menopause? Right? Two, were there any issues conceiving me or my siblings or my brothers? And I think sometimes people don't realize, like, oh, there was a 10-year gap between me and my brother. Was that because they had a hard time conceiving, or was that just because they wanted a 10-year gap, right? And a lot of times people, because you might see that, well, that could have been some underlying infertility, right? Like 40 years ago, patients didn't have fertility clinics as successful as we do, right? And if you take the trajectory of infertility, people keep trying and trying and trying and trying, odds are they have a good chance of conceiving on their own, but the whole point of fertility treatments is to shorten that time to conception, right? So I think one, that if you have a big gap between you and your siblings, if you don't have a concept of why that gap was there, maybe gently probing about why that was. The other thing is, I always ask patients, any genetic or developmental issues that you know of. And sometimes people will have like an uncle or an aunt or something that they're not really sure of, but I think that's also important to know. Or if anybody's had a history of a lot of miscarriages, patients may not know that, before them, their parents had several miscarriages. And I think that's important to know as well.
Right. I mean, me and you would know all of that about our family because we know what questions to ask. But oftentimes I have patients in my office, and more often than not, they're texting their moms when they're here because they're like, I don't know the answer to those questions. Yeah. And it's really cute to see them talk back and forth and find out these answers that can sometimes be really helpful and powerful about miscarriage history and menopause and endometriosis and all that kind of stuff. So hopefully
the best consults are when the moms are with them.
Exactly. I invite everybody to.
Yeah.
So if you were a fertility patient with everything that you know, what tests would you do before treatment?
So I would do a genetic carrier screen, particularly one looking for Fragile X. So Fragile X is a disease, Fragile X is actually a syndrome, okay, that's associated with developmental delay. What that is that it's a gene on our X chromosome that is made up of little repeats of the code. And depending upon the number of repeats we each have, there has the ability for that number of repeats to expand as our generations go on. And once it expands to a certain point, that can result in developmental delay. So I think that's important for all women to have that tested, because even if they don't have a low ovarian reserve, they could have the ability to pass on a gene that results in developmental delay to their sons. And not only that, even if they don't carry it, they could be an intermediate carrier, which then could pass on having a low ovarian reserve, or putting their daughters in a position where they then could have a son with developmental delays. So that's important. I would also do just a broad expanded genetic carrier screen, and I would do a karyotype just to make sure that there's no abnormalities in my chromosomes and that I am 46XX.
Perfect. And one other thing, especially if you have a cancer history, maybe just check that extra box for cancer genes too. Yeah. I did one on everyone in my family and my in-laws. They don't get a choice when you're related to me. So I was going to say something, but I totally forgot. Oh, it was so good. What was I going to say? It was really, really good. I forgot. Okay. What are your predictions for genetic testing in our future?
So I think that the genetic testing is going to get more precise when it comes to evaluating embryos. I think that we're going to make a change. So next generation sequencing, I think, is evolving and getting better. And I think it's going to get to a higher resolution in which we're going to be able to see not just whole chromosome abnormalities, but these subtle little deletions. Like when you do non-invasive prenatal testing now, and it's not only looking for an extra copy of chromosome 21, 18, or 13, a lot of them are doing these things where they're looking for micro deletions, which are associated with different developmental issues or complications with kids. So I think we're going to be able to look for not just large differences in chromosomes. I think we're going to be able to look for smaller ones too. I think with that, there are going to be some growing pains that come with it. Just like with NGS, we had the mosaic growing pains. I think there's going to be a lot of diagnoses of things that we don't know what to do with. But I think ultimately, in the long run, I think it's a good thing.
Wow, great. Well, thank you, Dr. S., for being a guest on our show and talking about all the genetic screening that fertility patients can do. We really appreciate you. Can you tell our audience again where they can find you and more about your practice?
Yeah, totally. Thanks so much for having me. So I'm in practice here in Orange County in Newport Beach, California. We're at OC Fertility here in Newport Beach, and we're part of the CCRM network. So we're part of CCRM Orange County as well.
Awesome.
But the website to go to for us is ocfertility.com, and on Instagram, I'm Dr. Nidhee Sachdev if you're looking for me.
Awesome. So I want everyone to follow her. And certainly if you're in Orange County or anywhere else that you want to go see her, please do. Well, thank you again for being on today's show, Dr. S.
Thank you so much for having me.
Of course. And everyone else, be sure not to forget to subscribe to my YouTube channel and sign up for my IVF class or Tushy class. And soon coming is my egg freezing class at eggwhisperschool.com. Thank you, everybody. Have a great rest of your week. Bye-bye.
Thank you.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Amy Sachdev.
And you have yet another success story
Just launched by an East Bay fertility doctor.